A BetterHelp ad. Therapy isn't just for times of major challenge. It's a valuable tool for anyone wanting to improve their well-being. It can help you develop healthy coping skills, set boundaries, and support personal growth. BetterHelp makes it easy to get matched online with a fully licensed therapist right from your phone. No commuting, no waiting rooms. And you can switch therapists at any time. Sign up at BetterHelp.com and get 10% off your first month. That's BetterHelp.com.
I'm here on the job site with Dale, who's a framing contractor.
Hey, good morning.
Dale traded up to Geico Commercial Auto Insurance for all his business vehicles. We're here where he needs us most.
Yep, they sure are.
We make it easy for him to save on all his insurance needs, all in one place, with coverage that fits his business and bottom line. Oh, I shouldn't have looked down.
It's all right.
We're so far up here.
Look at me. Take a deep breath.
No, I'm good. So good.
Get a commercial auto insurance quote today at geico.com and see how much you could save. It feels good to Geico.
Welcome to Unbiased Science, where we bring scientific method to the madness. I'm your host, Dr. Jess Steyer, and today I'm joined by two very special guests. One is a familiar face, our unbiased scientist, Jen Bordenick, but we have an extremely special guest, Dr. Nadine Gracia, who is joining us today to talk about trust, specifically trust for America's health. So today we'll be discussing the findings from the 2026 Ready or Not report. Amid deep staffing cuts, unexpected funding terminations, and other far-reaching changes to the federal public health system, this report finds wide variation in states' readiness as disease outbreaks, natural disasters, and other health emergencies become more frequent, and the U.S. prepares to welcome millions of international travelers for the 2026 World Cup. So, Dr. Gracia, thank you so much for joining us today.
Oh, Jess and Jen, it's really a pleasure to be with you. Thanks for the opportunity.
If I may, I'd love to read a little bit about Dr. Gracia's background because it is incredibly impressive. So bear with me for just one moment. So Dr. Nadine Gracia is the president and CEO of Trust for America's Health, a nonprofit, nonpartisan public health policy research and advocacy organization in Washington, D.C., committed to promoting optimal health for every person and community and making prevention and health equity foundational to policymaking at all levels. Hear, hear. She is a national public health and health equity leader with extensive experience in federal government, the nonprofit sector, academia, and professional associations. She served in the Obama administration as Deputy Assistant Secretary for Minority Health and Director of the Office of Minority Health at the U.S. Department of Health and Human Services. In that capacity, she directed departmental policies and programs to end health disparities and advance health equity, and provided executive leadership on administration priorities, including the Affordable Care Act and My Brother's Keeper. Previously, she served as Chief Medical Officer in the Office of Assistant Secretary for Health, where her portfolio included adolescent health, emergency preparedness, environmental health and climate change, global health, and the White House Council on Women and Girls. Oh my goodness, wow. We are in the presence of public health royalty.
You are too kind, Jess. Thank you. Thank you.
And may I call you Nadine moving forward?
Absolutely. Absolutely.
Okay, so let's kick this off with, I guess, a big question, which is, for the last 23 years, Trust for America's Health publishes the Ready or Not report, which, as we discussed briefly, is an annual assessment of the nation's public health preparedness. So why should we care? Why should people care about this right now?
Well, you know, Jess, again, thank you for the opportunity to be with you today and have really this important and timely conversation. And even after 2 decades of developing and publishing this report, why it matters today is, you know, we're in such a pivotal and critical moment as it relates to preparedness, our nation's readiness, when we've got a convergence, for example, of a severe flu season, most severe that we've seen in nearly a decade. We've got highest annual case counts of measles since what we've seen since 1991. Devastating weather-related emergencies, whether it's wildfires or hurricanes, flooding, or other types of disasters. The risks of other types of threats, whether known or unknown, and now being, of course, in the midst of the Hantavirus outbreak. The threats and the emergencies are increasing, and yet we're also seeing that happen at a time in which we have experienced a significant federal disruption in funding, in workforce staffing, and in our capabilities. And it makes assuring that we're paying attention to our preparedness and response systems even more important than ever.
So you mentioned the hantavirus, which we have to talk briefly about, if we may. We've been covering this on our page at Unbiased. Obviously, this is unfolding in real time. We're doing our best to keep up with the latest communications. But can you just share a little bit more about how this is a case study and the importance of these matters and how you see this playing out?
Well, the hantavirus outbreak is an example, right, of the types of infectious disease outbreaks that can happen, whether you anticipate them or not. And it's a demonstration of why we need coordination at the federal, state, and local level, as well as global coordination. It's why we need to have well-positioned preparedness and response systems. That's our health departments, our hospitals and health systems, emergency management, and other sectors that play a role in responding to these types of outbreaks. And what our report does in terms of ready or not is really highlighting that this is readiness for all hazards, whether it's infectious diseases, whether it's natural disasters, biological incidents. And the hantavirus outbreak demonstrates that you need to have that coordination to rapidly detect, be able to identify who is at risk, be able to provide the necessary services, treatment, access to care and support, do that coordination, and be able to contain an outbreak as quickly as possible.
This report is incredible, and we're going to link to it in our show notes. So as Nadine just mentioned, the report evaluates the nation's readiness for public health emergencies through 10 indicators of state preparedness, right? Including healthcare workforce mobility, state public health funding, laboratory surge planning, access to paid sick leave, and community water system safety. And then it places states into 3 performance tiers, right? And so there are 20 states in the high performance tier, 17 in that middle performance tier, 13 in the low performance tier. I was very excited to see that Massachusetts, which is where I live, is in the high tier. But can you tell us a little bit more about the scoring and those indicators and how you use them to make these determinations?
And what if you're in a low tier?
That's a good follow-up.
Great questions. Absolutely. So what, as you described it, Jess, this is, it's really an assessment of our nation's readiness by looking at state preparedness across these 10 indicators that really demonstrate core capabilities and the foundation of effective and strong emergency preparedness and response. And you noted some of them, whether it's healthcare workforce mobility, laboratory surge capacity, and other areas. What the report is doing is it's an annual assessment. So it's a snapshot of that 1 year measurement period where states, it's actually a comparative assessment in comparing how states are performing relative to each other. So when you look at the indicators, for example, if you look at healthcare workforce mobility, it looks at an indicator like the Nurse Licensure Compact, which states can adopt that in times of emergency, allow that cross-state nursing staff mobility to be able to help a state surge its workforce capacity. Because we know in emergencies, for example, a hospital may have higher pressures and demands because they may have a higher patient volume and load. So they're able to bring more nursing staff and personnel in to help support that response. It helps to eliminate some of the administrative burdens of licensure across states to say that nurses can move across these states more rapidly and effectively. It's looking at indicators like laboratory surge capacity, asking the question whether states have a plan in place such that when an emergency happens, they're able to actually increase and surge their testing capacity for a prolonged period, a 6 to 8 week period, to assure that they can meet the increased testing demand and need. It's also looking at state public health funding, and because that's critically important, that you actually have the resources for health departments to be able not only to prepare for, but to respond to those emergencies. And so whether states are increasing or decreasing that funding is also an important measure. When we look across the performance tiers, yes, states are placed in the high, middle, or low performance tiers based on their performance in those 10 indicators. And importantly, those indicators provide actionable data that policymakers at every level, whether they're local policymakers, state or federal policymakers, can take to strengthen their readiness. But importantly, it's also important to note that regardless of the performance tier, all states actually have strengths, all states have gaps, and all states have room for improvement. So even states in the high performance tier have areas that they can improve upon. States in the middle and low performance tiers, following on to Jen's question, is what it's demonstrating is, again, that there are some gaps and opportunities for improvement and areas that states can actually work to address. And sometimes you even see movement across years in those states. So it shows that it's not fixed, right? A state could perform in a high performance tier or in a middle performance tier and have some shifts in subsequent years. So it also demonstrates you have to sustain the effort. Preparedness is not a fixed thing. It's dynamic and it's constantly evolving. And so you have to continue to invest in and maintain attention to your preparedness and response systems.
Nadine, how did we do as a country, compared to prior years?
It's a great question. So what we can say if we look at this over the long term, and when I say longer term, I mean over the last couple of decades, as a nation, we have made progress as it relates to our preparedness and our readiness as a nation. You can look to a few areas, for example, such as strengthening our laboratory capacity. We've been able to expand that laboratory capacity, not only in terms of the testing to surge capacity, but actually the capabilities of laboratory testing and services. We've strengthened the coordination and collaboration between public health and healthcare, meaning the health departments and hospitals and health systems to be able to rapidly respond to emergencies. We've also strengthened the development and ability to distribute medical countermeasures. So things like vaccines, other therapeutics, and diagnostic and equipment that is needed in times of emergency. We've strengthened our surveillance systems, to be able to identify and address when there are emergencies. So over the long term, we've seen those areas of progress in preparedness and response. But that preparedness is at risk. And that's what this year's report is really pointing to, is that preparedness is at risk because preparedness needs continuity. Preparedness needs stable funding. It needs stable and sustained workforce. It needs assured coordination from the federal to the state and local levels. And what we've seen in particular over this past year is that disruption and uncertainty because there have been disruption in funding from federal to the local funding. And we've seen the workforce losses in terms of layoffs that have happened. And that puts preparedness at risk.
So you just walked through some of the areas of strong performance, right? So you mentioned the nurse licensure compact, the laboratory surge capacity, and other. There's public health and emergency management accreditation, community water system safety. This is nice to hear, right? These are strong performance indicator or areas of strong performance. But then there were areas for improvement. I saw several listed. Are you able to help talk through some of these and maybe which stand out to you as most important?
Yes, absolutely. So when we look at areas for improvement, certainly it's federal funding and workforce, the stability of federal funding and workforce. There were proposals to cut federal funding for public health and preparedness in last year's, the fiscal year 26 budget. And even though Congress actually largely rejected those cuts and kept it at level funding, there was still the instability that created and the disruptions that created. For example, last year, more than $11 billion were abruptly cut and terminated in terms of grants that went out to states and localities. That was COVID era funding, but the funding wasn't only being used for the pandemic response, it was actually being used as well to help shore up the gaps that were found in the pandemic response in terms of our health security. So whether that was modernizing our data systems, helping to have more electronic data systems so that hospitals and health departments can communicate the data more rapidly, and then that data can come from the health departments at the state level to the federal level at CDC more rapidly, to having the workforce capacity. That abrupt termination, we saw health departments, for example, that actually had to cancel vaccine clinics, immunization clinics in the middle of a measles outbreak, or had to lay off staff because that uncertainty with regards to the funding, it's very difficult to say, how am I going to pay the workforce? How are we going to assure services? And there's a disruption in those services. So even though, and we know that there's litigation around that, and some states are having that funding restored, the disruptions and even the delays of just getting funding out generally makes it very difficult to maintain a strong readiness posture.
Nadine? Yeah, I was just going to say, maybe just clarify for people, because I think when you think of federal funding cuts, I think, oh, a bunch of people in DC got laid off, right? And what you're talking about is funding that actually flowed to the states. So that impacted directly what my local health department, my state. Talk a little bit, just so people understand, when we're talking about federal funding, what that means.
That's absolutely right. So the cuts that we talk about in terms of what's happening at the federal level, they have a direct impact for states and local communities. I'll give the CDC as an example. 80% of CDC's domestic budget goes to states, local communities, community-based organizations, hospital systems, academic partners, and other external partners. So when there are cuts to CDC's budget, those cuts directly then affect state and local budgets. It's very difficult for states to be able to have the level of resources, especially when we look at for rural areas, other underserved areas, but really across the board for states, they rely heavily on federal funding. So when I described that $11 billion that was abruptly terminated, that then had a direct impact on states being able to respond to not solely COVID, but things like the measles outbreak, or just day-to-day public health prevention and emergency preparedness work that states and local communities do. There's also an impact, not only in terms of federal funding, but the federal workforce. When you see the layoffs that are happening at an agency, for example, like CDC, not only is CDC providing funding to states and local communities, what it's also doing is providing technical assistance and support and expertise to those states and localities. And so when you see cuts and these layoffs in terms of the workforce, I'll give as an example, when there was the lead crisis in Milwaukee, Wisconsin, when the health department actually made the request to have support from CDC to help in addressing that lead crisis in schools, at that time, the CDC was not able to send staff because the staff for the lead poisoning prevention program had been laid off. Now, those staff have been returned to the CDC, but when the locality actually made that request, they didn't have those experts available. That's the direct impact that can happen when you make those kinds of cuts to an agency that not only provides funding, but also provides experts and technical assistance and support directly to states and local communities.
So did we see that this year, like with the outbreaks, the measles outbreaks in the different states, they had less funding and less resources to respond to the measles outbreak, maybe in South Carolina or Texas or Utah or wherever?
So what we saw were disruptions in funding or delays in funding, and that was across different types of programs. And that creates a level of uncertainty for states to be able to not only respond to, but also be able to more readily prepare for different types of threats. And that's why, for example, we have the state funding indicator in the Ready or Not report to look at how robust then are the state resources as well, because if there is that uncertainty at the federal level, we know that having the state resources is vitally important, but it doesn't replace the need for support from the federal level, just given the breadth and the depth of these types of emergencies.
Being outside is good for us. It's that simple. And trails make it easy for us to walk, bike, and be active outside in our own backyards. On the trail, we see people moving, connecting with their communities, making the places where they live great. For 40 years, Rails to Trails Conservancy has led the way, creating trails across the country, making it safer and easier for everyone to get outside. They want you to get involved. Find your trail and start your journey today at railstotrails.org/iHeart and follow at Rails to Trails on social.
Hey, listen. Can you hear that? That silence is the sound of a $3,000 vet bill because you don't have Lemonade pet insurance. Your dog just snuck away to swallow your phone charger, which will land him at the vet. Thankfully, Lemonade Pet could save you up to 90% on vet bills. And the earlier you sign up, the more it could cover for your puppy or kitten. But in the meantime, if you hear this, you should probably go check on what your puppy is up to. Get a quote at lemonade.com/pet.
So back to my other question. So if I have family in one of these low tier states, what does that mean for them?
So one, as I said earlier, every state shows, and when you look at across the data, shows that it has strengths. But it also shows that there are areas where they have gaps and areas where where states can take actions, the policymakers, health officials, and other leaders that can take actions. We've seen, for example, for states that are in the low performance tiers or in some that are in the middle performance tiers, reasons that they're in those performance tiers is more so because they may have less stability in terms of their state public health funding, right? Other areas is that they may have lower vaccination coverage or accreditation, whether that's public health accreditation or emergency management accreditation. And we see that with those accreditation, we've demonstrated that that those states tend to have stronger coordination and response capabilities. And so I think the important aspect of that is that there are actually actions that the states themselves can take. It's not solely dependent on the federal funding, but states, for example, can assure that they are investing in public health in their state and really assuring that there isn't this type of fluctuating investment in public health. Far too often, we see that public health is funded on this kind of boom and bust cycle, right? The emergency happens. I see Jess nodding her head. The emergency happens, and all of a sudden there's this influx of funding that happens to respond to the emergency, whether it's the measles outbreak or it's COVID-19 or it's a wildfire. And then once the emergency subsides, that funding either is diverted to other areas or the funding itself ends. And then we return kind of to this austere state for public health funding. That is in a way to have a strong readiness and response system. So states can take action to assure that they are investing in public health. They can also do more to really promote vaccination and try to address, which I know is a huge issue, not only access to vaccines, but trust in vaccines and their roles that states can also play to elevate that, because we see just the growth of the number of infectious disease outbreaks that we're seeing in the country across states.
So Nadine, we've talked about funding, workforce stability, state public health funding, all critically important. There were some other indicators or areas for improvement that stood out to me that I thought were really interesting. So things like paid sick leave, I didn't realize it varied so widely across regions. So it was 98% of workers in Pacific states to 67% in East, South, Central states. Gaps are most concentrated among low wage, part-time, and service sector workers. Obviously, this has lots of implications, right? Paid sick leave reduces disease transmission, supports business continuity, and all of these other critically important things. Then in the report, you also talked about hospital patient safety. This blew my mind that in fall of 2025, only 27% of graded hospitals earned an A from the Leapfrog hospital safety grade. Avoidable mortality showed up, infrastructure and environmental risks. Can you talk about maybe some of these other indicators that we haven't talked about yet that stand out to you?
Absolutely. And I think you lifting up those indicators just demonstrates how preparedness, readiness and response, it really is a cross-sectoral issue, right? In terms of being able to assure that communities are ready for whatever types of health emergency happen. So let's take the access to paid sick leave. As you pointed out, if you don't have access to paid sick leave as a worker, many workers, especially those who are in part-time positions, but other types of areas of work, have to make difficult decisions about, do I go to work sick, or do I lose, income and possibly even my job if I can't show up for work? And so it's really an access to paid sick leave is actually an important measure of preparedness, because if you think about an infectious disease outbreak, the ability to assure that businesses' employees can actually stay home if they are sick. You can, one, help reduce the risk of spreading that infectious disease. You also help to promote your business continuity in terms of business operations. And so now actually more and more in the business sector are seeing paid sick leave as a business imperative, and they're understanding it as a readiness imperative for their companies. We see, for example, partners like the Health Action Alliance, which is a largest network of businesses that work at the intersection of business and public health, in their pandemic playbook have access to paid sick leave as an important component of preparedness. And the other thing is that it's with that driver, it's not only the health imperative, but it's also economically, right? Preparedness is helping assure our health security. It's also helping to assure our economic security as well, and a strong economy. When we look at things like patient safety, this again, and across these indicators, as you're seeing, it's not specific to any one type of emergency. It's really looking at the foundations of emergency preparedness and response. And so patient safety and hospital safety really has a clear correlation to preparedness, because what we know is that the hospitals that achieve that A safety grade, it's demonstrating hospitals that have one, great protocols in place in terms of infection control, medication safety, have clear clinical processes that help to reduce errors. And when you can do that at a baseline, when there's not an emergency happening, you are then more likely, when there is an emergency and you have greater stress and strain on a hospital because you have more patients coming into the emergency department, staying in the hospital, that you're prepared for that. So there's definitely room for improvement there. Now, though, that is to be clear, if a hospital did not achieve an A grade, doesn't mean that a hospital isn't safe, but it definitely means what it's conveying is that there are opportunities and room for improvement in terms of patient safety. When we look at avoidable mortality,
that's scary.
In every public health emergency, we can talk about the access to care and the clinical interventions, but we also know that there are significant disparities that exist, whether it's in rural areas, underserved areas, in many communities of color, in communities that have low incomes, that face longstanding disparities. And avoidable mortality is saying these are deaths that could be prevented with either through public health interventions or through healthcare interventions. So think of public health interventions like vaccine preventable diseases, as we've been talking about, or eliminating exposure to lead, or reducing suicide or overdose through behavioral health interventions. Whereas with the healthcare interventions, we're talking about things like, if you have a heart attack or stroke, do you have ready access to quality health care? And so there you see, with regards to avoidable mortality, truly across the nation, a need to address that, because what we see is that in communities and states that have less of avoidable mortality, they are more prepared, more resilient to withstand and recover from those emergencies, because our health, as we know, is not simply driven by what happens in a doctor's office and in a hospital, but it's also in the community conditions that then promote our overall health.
And this is probably a bigger factor for people in those rural areas.
Yes, we do see, for example, disparities in rural areas, because again, when we talk about access to healthcare, we've seen many hospital closures that have happened in rural areas, access to the resources, health departments that have less resources, as well as greater workforce shortages. We entered into the pandemic. And it's, I think, important as well to understand that public health as a system has been chronically underfunded and understaffed. And rural areas have seen that in particular. And so these are areas certainly for rural areas to address, but it's really across the board in terms of strengthening and reducing avoidable mortality for the nation.
So now maybe we could shift gears to talking about the recommendations for how do we take all of this and move towards improving our emergency preparedness? What would you say are some of those top recommendations that you walked away with from this report?
Yeah, so the report, as we've been talking about, provides that data, actionable data, and then recommendations that policymakers at all levels, federal, state and local level, health officials and others can take to really strengthen our readiness. And I'd say some of the areas that policymakers can begin with is assuring that there is sustained, predictable funding for public health and health security, that it cannot be this kind of waxing and waning investment in public health and emergency preparedness, because you have to not only build the systems, you have to maintain the systems and strengthen those systems over time. Other actions that can be taken are to assure that we have a strong and trained workforce. And with the workforce cuts that have happened at the federal level, but to the earlier part of discussion, it's also if states and localities are also seeing these challenges around their funding, then they're also having to make layoffs in their health departments, that we need strong and sustained funding to have a strong and sustained workforce as well at all levels. And we see that in action. And to go back to hantavirus, when we talk about people that are being monitored, actively monitored in those states, those are the health departments that are doing that monitoring. And so we have to assure that states have the workforce to be able to do that active monitoring, communicate with the federal agencies, and be able to help contain the outbreak. It's also modernizing our data systems. Before the pandemic, we heard so many stories of health departments, for example, that were still faxing in data, using Excel spreadsheets to transmit data in terms of what was happening with outbreaks or other types of health data. And because of the investments that have been made in data modernization, we have more electronic data, and that speeds up how quickly data can be transmitted. It helps assure that we can communicate that data between hospitals and health departments more rapidly. And doing so, we're talking about how we can better address these types of emergencies. And the ultimate goal is to save lives, really protect the health of communities. That kind of modernization is critically important. These are actions that policymakers can take. And I'll say one thing that Congress can do right now is reauthorize the Pandemic and All Hazards Preparedness Act.
Talk about that.
Yeah, so which is commonly known as PAPA. That is the legal framework that is the foundation of public health emergency preparedness and response. This year is, as many know, the 25th anniversary of the 9/11 and anthrax attacks. And those attacks really shined a spotlight on the gaps that we had in terms of our preparedness and response systems as a nation and across states. And it elevated public health's role in emergency preparedness and response. And the Pandemic and All Hazards Preparedness Act was a law that was enacted shortly after those attacks. And it set it set a framework for public health emergency preparedness. It led to greater coordination of public health and healthcare. It led to investment and specifically programs and funding for public health emergency preparedness. Programs, and I'll give an example of two. One being the Public Health Emergency Preparedness Cooperative Agreement, that program, which CDC funds to states and several of the large cities. And that program has helped states and those large cities like New York and Chicago, Los Angeles, and others, DC, to be able to build the emergency preparedness workforce in their health departments, to modernize their data systems, to develop their laboratory systems so that they are better prepared for biological incidents, for weather-related emergencies. It also then provided funding and creation of the Hospital Preparedness Program. That Hospital Preparedness Program is the primary source of federal funding to the healthcare delivery system for preparedness and response. That's to be able to do the training and the exercises, right, to prepare for large-scale events like the FIFA World Cup, to prepare for natural disasters or extreme heat, where we know people there may be rises in heat-related illnesses and people coming into the emergency departments and overwhelming, for example, emergency departments, be able to do those kinds of training exercises. That's what that law has done. And Congress now can reauthorize it. It has enjoyed bipartisan support.
What does that mean? Can you talk about that, Nadine?
About having bipartisan support?
Well, reauthorize it. Does that mean it's not in effect right now?
So there are provisions of the law that will carry forward, but it by reauthorizing it, one, Congress would be sending a clear signal that it supports a strong readiness and response posture for the U.S. and across the country. Two, right now, what's happening is that there are provisions of the law that are being extended for shorter periods. But again, remember I said earlier, preparedness depends on continuity. And so since that law, for example, provides the legal framework around our preparedness and response systems, it also lays the groundwork in terms of those programs that I just mentioned, hospital preparedness, public health emergency preparedness. It's important to have that type of continuity in terms of those authorities and the investment and funding for those programs, so that it's not it isn't as episodic in terms of when an emergency happens, then we're making those investments in those programs itself. And again, that has long had bipartisan support, because the understanding was that, these emergencies, they don't recognize geographic boundaries. They don't recognize political boundaries. They can happen in any community and in any state.
So Nadine, as we wrap up here, are there any key takeaways or final thoughts that you'd like people to leave this episode with?
I would say that a couple of thoughts is, one, we have had progress, as we talked about earlier, progress over these recent decades in terms of preparedness, but that progress really is at risk. And the emergencies that we're seeing today, they are really a reminder, but they're also serving as a warning that we have to invest in emergency preparedness and response and public health and prevention at large. That we cannot build these systems when the emergency happens. It's not in the middle of the crisis that we then provide the resources and support to public health and preparedness. We've got to do this before the crisis happens. We've got to assure that we have the workforce. We have to assure that we have the capacities in terms of our labs, in terms of our surveillance systems, and that we have to have strong coordination at the federal, state, and local level. It's an interconnected system. No one part of the system can respond to these emergencies alone. It's an interconnected system. And if we do so, we save lives, we protect communities, and we're a stronger nation for it in terms of our health, in terms of our economy, and in terms of our overall national security.
Incredible. Thank you so much to Dr. Nadine Gracia, President and CEO of Trust for America's Health. We will link to this 2026 Ready or Not report so you can all read it yourselves. Thank you so much for joining us. Thank you to our listeners for listening in. We hope you learned a thing or two. I certainly did. And we'll catch you next week on your trusted source for no nonsense, just science.
Being outside is good for us. It's that simple. And trails make it easy for us to walk, bike, and be active outside in our own backyards. On the trail, we see people moving, connecting with their communities, making the places where they live great. For 40 years, Rails to Trails Conservancy has led the way, creating trails across the country, making it safer and easier for everyone to get outside. They want you to get involved. Find your trail and start your journey today at railstotrails.org/iHeart and follow at Rails to Trails on social.
If you like the show, please take a moment to rate, review, and subscribe. It really does help the show to grow. Thank you for listening.